the DHMOSH, the first session of our DHMOSH Public Health Leadership Seminar Series entitled History of the Military and Infectious Disease. We'll also be sharing some leadership lessons for public health leaders. So my name is Dr. Esther Tan, and I'm in charge of a public health section of DHMOSH. DHMOSH stands for Division of Healthcare Management and Occupational Safety and Health here in the UN headquarters in New York. Today, we have the privilege of hosting Dr. Stephen Thomas for this presentation. So just a quick word about this whole seminar series. So this leadership series is really targeted at our UN staff who work in healthcare or public health fields. And it has three purposes. One is to empower you with foundational tools to improve public health practice in your duty station. Secondly, to prepare you to respond to a range of public health emergencies in your duty station. And then thirdly, it's for you to build effective leadership and management skills. If we could just mute everybody, that would be great.
His wife has COVID-19. So we told him.
Mike, can you just mute people who are not?
Yeah, it seems that I was not able to set it or it changed in the setting.
Could all of you
Dr. Tan, you'll need to unmute yourself. I think I've been given, I muted everybody, but each person can unmute themselves if they want to ask.
Okay.
Okay.
Great, thank you. Yeah. So if you've not checked out our website, we have a website that gives you the different public health programs that we offer, and we'll put it on the link on the chat. And if you want to be on the mailing list for future webinars, please sign up on the link that we'll be posting on the chat as well. So if you have any questions, please put it into the chat. And then also note that this webinar is being recorded, and we will send a link to all of you after the talk. So today, I'd just like to introduce our speaker, Dr. Stephen Thomas. So Dr. Stephen Thomas is a professor of medicine, professor of microbiology and immunology and infectious disease and physician scientist from SUNY Upstate Medical University. He is also director of the Institute of Global Health and Translational Science and the interim chair of microbiology and immunology there. So prior to joining the university, he had spent 20 years in the US Army, serving at the Walter Reed Army Institute of Research, and completed his career as the Institute's Deputy Commander for Operations. Dr. Thomas specializes in the study of viruses and vaccine development and spent more than 5 years of his early career living and working in Thailand. He has played key leadership roles in the US government's response to the West African Ebola outbreak, the MERS-CoV outbreaks and Zika epidemics, and was instrumental in development and advancement of vaccines for each of these diseases. So without further ado, let me hand over the floor to Dr. Thomas. He'll be first presenting a short talk on leadership lessons for us as public health practitioners, and then followed by the topic of the history of military and infectious diseases. And then we'll end about 10 minutes of question and answer right at the end. So over to you, Dr. Thomas. Thank you so much for doing this for us.
Thank you very much, Dr. Tan. I really appreciate the opportunity. It's really nice to be here with everybody, and I appreciate your interest in what we're going to talk about. This first part on leadership is really kind of a teaser, a preview. I think this is a topic that we could spend multiple days talking about. So I just wanted to give maybe just a hint at what we will discuss, hopefully at a future time, if time allows, and I can come back. My perspective on this is, leadership during COVID. It really is the same approach that I've always taken to leadership. It was just sort of a different problem that needed to be tackled. My experience, as has already been mentioned, I was an officer in the U.S. Army for about 20 years. And in the military, very much like your organization, you have two main roles and responsibilities, and you have two areas of technical competence. One is either policy or logistics or medicine, science, whatever it is, human resources, whatever role that you play in the organization, you have to be technically competent and you have to be an expert. But at the same time, we all have a parallel expertise that we are required to develop, which is leadership. And I have found that in lots of places that I go, sometimes people believe that because you have technical expertise or competence in a certain area that you're automatically qualified or have these skills and the abilities to lead in that area. And that, of course, is not the case. And so, at the same time that I was receiving an education and training and experience as a physician and as a scientist, we were also required to take, lots and lots of training and education in principles of leadership and how to lead people and manage people and manage resources, et cetera. So a lot of when someone talks about leadership, they really are reflecting to you their perspective and their journey and where they've been. So, as was mentioned, I trained in the military. So I trained at the Walter Reed Army Medical Center. And that first 6 years is where I learned how to take care of patients. And then once I was trained in infectious diseases, then I joined the upper right here, the Walter Reed Army Institute of Research, which is the Department of Defense's largest biomedical research and development laboratory. And we have about 2,100 employees, laboratories on four different continents, and an annual operating budget of about $300 million a year, which is 95% soft money, meaning that money has to be competed for, and it's acquired through grants and contracts and these sorts of things. As was mentioned, I spent about almost 6 years living and working at the middle organization here, which is the Armed Forces Research Institute of Medical Sciences. That is in Bangkok, Thailand, and that's sort of the hub for all the spokes that go out throughout Southeast Asia. And so I was able to do 2 tours of duty there and do all sorts of interesting work in Thailand and the Philippines and Cambodia and Nepal and other places. When I came back just prior to taking my leadership position as the Deputy Commander for Operations, which is essentially the Chief Operating Officer for the Institute, I deployed to Jordan and was part of Central Command in Jordan down in 2013, 2014, which is when a lot of very interesting things were occurring, to include a humanitarian crisis in Syria. And I was working with the Royal Medical Services for Jordan, who was responsible for basically trying to ensure the health of the entire country, since about 30% of the general population accesses the military medical system. And when basic medical care and public health and preventive measures were breaking down in Syria, to include vaccines against routine diseases, then it became a very concerning situation with polio and measles and other kind of diseases. And then, as Dr. Tan mentioned, my last 2 years in the military, I thought was going to be a time to reflect on a career and take it easy a little bit. But it turned out that we had the Ebola outbreak in West Africa, and we sent President Obama sent 3,000 service members to try and help the global effort there. We had the Zika outbreak, and then we had MERS-CoV. So that's kind of part of the perspective, that leadership perspective I have. And then I went to academia, and so the other part of the perspective I have is primarily been shaped by this by COVID. And I was the incident commander for my hospital. So I'm in Dr. Tan's down in New York City. I'm in central New York. So we have about 10% of the state's population here. We have urban centers. We have very rural and agricultural centers. So lots of diversity within our population. We cover about 19 different counties. So from Canada to Pennsylvania, we have a lot of people. And we have about 11,000 employees in the hospital spread out over multiple places. And we needed to, and we are looked at as sort of the medical and scientific experts in the region. And so it was our job to try to come up with ways to protect not just our 10,000 or 11,000 employees, but also to protect the region. And so I was the incident commander for the very beginning, from basically March to June. And that really shaped a whole different set of leadership lessons. So when I give the actual talk, I have a number of different what I thought were key leadership lessons or elements that that I learned and relearned and implemented. And so I will talk about things like being organized and ensuring that you have cross-functional teams of teams, that approach, understanding your leadership limits in terms of what responsibilities do you have, what authorities do you have, and what resources do you have. I'll speak about communication, not just clarity in your communication, but ensuring that you communicate with intent. I talk about decision-making and the importance of not just making decisions, but how you make those decisions. Especially in the types of situations that you all find yourselves, and certainly in a rapidly evolving pandemic. Things are changing so fast, and the balance between centralized and decentralized decision-making is really paramount and important. So I talk about disciplined initiative, or the concept of frontline leaders being able to change plans when the conditions, either in the hospital or on the battlefield or wherever you are, when those conditions change, having frontline leaders being able to take disciplined initiative and make changes. And then I talk about risk and how to calculate risk and how to accept risk and how to convince others to accept risk. And then this slide here just reminds me that I put a lot of, try to keep it interesting and put a lot of historical context and tell stories of people who I think are great leaders, such as Sir Ernest Shackleton, who in the early 1900s went down to try and traverse the South Pole, and their ship, the Endurance, got caught in the ice, broken up, and his entire crew got stranded in the middle of nowhere in very difficult conditions. And it's it's an incredible story how they were all brought back safely. So if hopefully we can find a date in the near future, and I can kind of go into the details. So I will stop sharing that presentation.
Yes, and we would love to welcome Dr. Thomas back again for another time where he can expand a little bit more on the leadership lessons. But for now, we're just going to move ahead to the next session on the military and infectious disease. Thanks so much.
Okay, great. Okay, so you can see that, Dr. Tan?
Yes.
Okay, great. Thanks. So this is entitled, the history of the military and infectious disease threats. But I do want to mention that the military is just, represents my experience and something that I know pretty well. But it really, the military, they are travelers, right? So really this represents, and I cover topics which apply to all travelers, whether it's in the military or whether it's in UN forces, whether it's in the expatriate who either travels for work or goes to live in a different country. And I tried to pick, obviously we don't have a ton of time, so I had to kind of pick and choose what I thought were the most pressing and most important issues. I do not really talk at all about COVID, because that's a whole other kind of separate thing. So even though I use the military as the example, it really is very generally applied to lots of different groups. So that's one part. The other part is that I've given this talk to primarily medical personnel in the past, and I get really deep into diagnosis and treatment and whatnot. I'm not doing this here because I know that we have a very diverse group of people that serve the mission in many, many different ways. And so I'm going to try to stay kind of top level if possible. And hopefully people will leave this talk just understanding a little bit more about infectious diseases, how they are a threat to the population, the global population. What are some specific threats that are out there, and how they have impacted different groups. So disclosures, I as an academic, I'm I'm not with the government, I'm not with a private entity, and so I get called upon a lot to support different groups, either on advisory boards or safety boards, et cetera. And this is the list of those. I've already told you, I want to talk a little bit about the historical perspective on the emergence of infectious diseases, drivers of emerging infectious diseases, and then okay, so infectious diseases. Obviously, the planet has experienced numerous outbreaks over time. SARS and even pandemic flu were not the first ones. And you can look at the plague of Justinian, which they estimate killed over 100 million people. Black Death in Europe, which killed about 25% of the population. The influenza pandemic back in the early 1900s, which they think killed anywhere from 25 to 50 million people. And then we've had multiple different cholera outbreaks over time, with some of the first being documented back into the late 1800s. And you can identify a lot of different trends which kind of led to this. So one of the first was this domestication of livestock, right? So animals have diseases that are inherent to animals. People have diseases that are inherent to people. And when you start to mix the two, things can happen. And so when we started to domesticate livestock 10,000 plus years ago, we started to see zoonoses, right? So we started to see diseases that jumped from animals to people. And domestication of livestock also encouraged people that typically lived on their own to now start living more closely together. And so we started to create these settlements, and then settlements became cities. And what that meant was you had a lot of people who were not immune to all these different diseases now living together. And so you had a lot of susceptible people living closely together. But living together also required civil services, meaning, what do you do with human waste? What do you do with garbage? What do you do with spoiled food? What do you do with dead animals? What do you do? All these types of things that we know can foster disease. How are we going to handle them? And then people started to move. They migrated, they traded, they explored, they went out to conquer other lands, and they brought with them pathogens. And so places that had never seen smallpox before, for example, or syphilis, now we're experiencing disease outbreaks that were not endemic, that were not previously endemic to those areas. Well, we started to advance our understanding of infectious diseases, and we started buying into germ theory. Penicillin was stumbled upon us, so we entered the antibiotic area. We started to postulates of how to identify microorganisms and causing infections. And then we started to think that we could actually eradicate infectious diseases. And there were lots of people who thought that we were going to conquer infectious diseases, that they were going to become a thing of the past, that we were going to end up in this kind of commensal living situation together. And we're going to move on and just really be dealing with chronic diseases. So diabetes, heart disease, trauma, cancer, these sorts of things. But of course, that didn't happen. And the wake-up call was in the 80s when HIV and AIDS started to be recognized as a new disease entity. And as that story evolved, and it went from people thinking that it was just small subgroups of people that were at risk, and it became a risk to everybody, that really got us to refocus on infectious diseases. And groups like the National Academy of Sciences, CDC, and even the President of the United States started to understand that infectious diseases were not just a healthcare issue. They were not just a public health threat, that they actually were threats to national security, regardless of what country or region you were in. And this, of course, was driven home by the Ebola outbreak that we saw in the 90s in Kikwit. And this is about the same time that Hollywood started to pick up on these stories and make it a more mainstream concept. This is our national security strategy for the U.S. From the last administration in December of 17. It was published, and the three main tenets are to detect and mitigate outbreaks early, to take a One Health approach. So One Health is the pathogen animal-human interface, and to make sure that we work with all of our international partners to ensure biosafety, biosecurity, biosurety in the laboratories that are working on these diseases. And this is one of Tony Fauci's favorite slides. He updates it every time he gives his emerging infectious diseases talks. There really is no room left on the slide to show all of the examples of emerging and re-emerging infectious diseases. The world is full of them. They're everywhere, and we really can't we really can't find a respite from them. So we have to deal with them head on. This is the only COVID slide. I pulled it from this morning, 6:21 a.m. Today, and you can see what the latest numbers are. 208 million documented cases. You can probably multiply that by 5 or 10 to understand the true burden. Same thing with deaths. You could probably multiply that by 2 to 5 to understand how many people have truly died of this disease. And we are. This is just another example and a continuation of the story I was just telling you. And what's driving this infectious disease threat is largely human behavior. Population growth, moving into urbanization and moving from rural environments into large, huge cities and mega cities, poverty and social inequity, war, famine, breakdown of normal public health infrastructures, immunization programs, et cetera, climate change, and just the lack of will that politicians and others who control resources are willing to dedicate to preventive measures. And unfortunately, these trends continue. So infectious diseases and the military. So this is a picture of Major Walter Reed. He led the 4th commission, Yellow Fever Commission, down to Cuba and in the late 1800s, early 1900s to kind of chase down a Cuban scientist, Carlos Finlay, to chase down his theory that yellow fever was transmitted by a mosquito, which he did. So the Department of Defense really has invested for a very long time in global health and infectious diseases research and development, and you can see the list of and the wide range of infectious diseases that the U.S. military infrastructure cares about. Many of these are not endemic to the United States. Most are not, but they do reflect that this is a very expeditionary force, much like you are, and that when you travel to areas that have diseases, you become at risk for those diseases, and so you need to develop countermeasures. The other reason is that when you look at the deaths that we have seen from these infectious diseases, although relatively small in number, they are incredibly impactful, and they drive the research and development enterprise to try to come up with ways to mitigate these infectious diseases threats to our military forces. So kind of looking at some of the specific threats, and again, I chose these because I think that they are they're prevalent. I see them not just in the military, but also in the civilian travelers. And so it's not comprehensive, but I chose what I thought were the biggest threats. So the first is traveler's diarrhea. So you can travel, I could travel from here to Florida, and I have a 5% chance of getting traveler's diarrhea. So traveler's diarrhea does not necessarily have to be due to a specific pathogen. It's a big change in our daily routine. It's a change in stress levels. It's a change in how we eat and how we drink. And so about 5% of all travelers will get diarrhea. Now, when you're looking specifically at traveler's diarrhea, you can see here the hotspots on the planet. So anything in red or brown is considered a hotspot and a high risk for developing traveler's diarrhea. So if you are deploying to any of these regions of the world, diarrhea has to be on your list of things that you have to think about and how you're going to mitigate that risk in your people. In the U.S. Military's experience, so you can see that what we've had is this is looking at different organisms that cause diarrhea in the force over time, and so there's a couple of trends. One, the top line, which is the black dotted line, you can see here, unspecified gastroenteritis or diarrhea. So the bottom line on this is the best fit line is one that is increasing. So we're seeing more diarrhea in our deployed forces. The next is that Campylobacter, which is the orange line here. This used to be the most common cause of traveler's diarrhea in our forces. It continues to be a major player. but Norovirus, which is this red line here, that's where we've seen the greatest increase in incidence and prevalence in our deploying forces. And anyone that has been part of a norovirus outbreak knows that it can quickly go through a unit and make that unit ineffective in terms of its mission. In terms of guidelines for the prevention and treatment of travelers' diarrhea, so this is from the Journal of Travel Medicine. I really like it because they got a bunch of experts together and they looked at all the data, they looked at all the information, and they tried to make very practical advice. The first, and I get asked about this a lot, antimicrobial prophylaxis is not recommended. So we do not automatically give people prophylaxis when they are traveling. It breeds resistance and it results in adverse events from antibiotics, and we don't recommend it. There are some caveats to that, but that they are very few and far between. The second is that these bismuth subsalicylate, so in my country, like Pepto-Bismol, for example, those can be considered for any traveler to prevent travelers' diarrhea. They're very well tolerated. They're over the counter. They're easy to take, and they work. Number 5, so fluoroquinolones. It used to be that people would always get ciprofloxacin or levofloxacin or ofloxacin before they would travel and told, oh, this will prevent diarrhea. They have a side effect profile which you really need to understand, and they also have a great deal of there's a great deal of resistance out there from different organisms, and so they won't work. And Campylobacter is a good one, for example. So the bottom line here is we really do not recommend prophylaxis for either individuals or groups of people, except in very rare circumstances. The second is, in the event that someone actually does get ill, we really try to look at 2 things. So we look at functionally, how is this impacting the person? Is it mild, moderate, or severe diarrhea? We look if it's in the severe category, whether it's dysentery or non-dysentery, meaning is there a big inflammation component to the diarrhea, bloody stools, for example, or not? And then we make decisions about how we're going to manage it. Are we going to use antibiotics or are we not going to use antibiotics? The vast majority of people who get travelers' diarrhea, it's going to self-resolve. The threat from travelers' diarrhea is when people cannot maintain the balance between what they're taking in and what is coming out. And therefore they can go into, especially for younger people and children, and they can go into shock because what's leaving through diarrhea and vomiting, they can't keep up with oral rehydration. So typically diarrhea that's mild. So this means that you have diarrhea, but you can leave the hotel, you can do your job, you can do the other activities that you've planned. This can be managed just with either loperamide or bismuth compounds. Again, Pepto-Bismol where I live. If it's moderate, that means it's interfering with your daily activities. In these cases, this is when we start to consider antibiotics. Now, there used to be this dogma that, well, you don't want to give loperamide and antibiotics, but the studies have shown that you actually can do that. And when you use loperamide in addition to antibiotics, you actually reduce the duration of illness by almost a day, which anyone who's had traveler's diarrhea knows a day is a big deal. And that's a significant improvement. Now, when we get to severe diarrhea, this is diarrhea that's really incapacitating, and it's not just interfering with your activities, it's preventing your activities. And this is where I start to think you might not want to use something like loperamide, and you absolutely should consider using antibiotics to treat it. The concern would be that, but again, this is non-inflammatory diarrhea. When you have dysentery and there's a potential toxin-producing form of diarrhea, this is where it gets a little complex, and you should consult with an expert in diarrhea, because antibiotics could potentially be harmful, which is why they do not have an antibiotic block here. And just so you're aware, I mentioned already, there's such a high rate of resistance, especially in Campylobacter, to the fluoroquinolones, that azithromycin has evolved as your go-to for the treatment of travelers' diarrhea. So it's 500 milligrams by mouth, a 3-day course. If they don't get better from that, then they may have a non-bacterial cause of diarrhea. Okay, so that's travelers' diarrhea. In terms of influenza, so this is a picture from the influenza pandemic of 1918 at a military camp out in Kansas, in my country, and you can see it's full of young, otherwise healthy people who are suffering from flu, many of whom died. So the first thing that I would say is influenza is a risk to travelers, and it does cause major problems, especially in tropical and subtropical countries. And it really is, but this study and others have shown that flu is really one of the most frequent vaccine preventable diseases that afflicts travelers. So you need to think about flu. The other thing you need to think about is that influenza has a seasonality to it, which everybody knows, but it differs depending upon where you are on the planet. And so you may be in the northern hemisphere, for example, and you may be traveling to the southern hemisphere. And if you're doing that, you need to think to yourself, well, it may not be flu season here. Is it flu season where I'm going? And do I need to make sure that people move up their influenza vaccinations? Yes or no. So you can see in the light green are areas where the influenza season is April to June. So South America, South Africa, South and Southeast Asia. In dark green, it starts moving to July to September. October and December is the light, I guess that's teal, light blue, et cetera. So you really just, and you can consult with the CDC or your local Department of Health to where you're going to understand what flu season is. But it's something that I've seen a lot of travel doctors who they forget about flu. They forget about that it's a different flu season depending upon where you're going, and they forget to get people vaccinated. I think this is very interesting. So this looks at U.S. outpatient influenza-like illness visits, and it gives you the percent of illnesses in an outpatient setting at these specific centers that are related to influenza-like illness. Each color represents a different year. So in the green, you can see the 2019-2020 season. And in the blue, you can see the 2018-2019. We had a big year in 2017-2018. And so basically what it represents is about 5 to 8% of all visits during the fall and winter, at least in the United States, are related to an influenza-like illness. I pointed out because the red triangles here represents what we've had in 2021. I do not, so obviously very, very low. I do not think that this is some kind of viral competition between SARS-CoV-2 and influenza. I think that this is the same thing. The RSV curves would look the same. And I think it's because of public health interventions, masks, physical distancing, non-gathering, et cetera. Everyone should know that every year, the World Health Organization and a number of other public health organizations around the world get together. They assemble all of their influenza surveillance data. They look at all the sequences of the viruses that are infecting people around the world, and they make their best guess at what components should be in the influenza vaccines for that season. And so I just pulled this from the FDA's website. So this is a meeting in March to determine what's going to be in the 2021 season. And you can see here the different strains that were selected for quadrivalent vaccines and trivalent vaccines. And this long list of letters and names here give you an indication of where the isolate came from, that it's a type A, and what the hemagglutinin and neuraminidase makeup is H1N1. This is an H3N2, et cetera. So it's just something for you to be aware of, in case you're wondering how they actually select the strains. Okay, so malaria. So this is from the World Malaria Report 2019. It is a heat map. It is basically showing 2018 data, malaria incidence, and you can see going from green to maroon. The darker that the color gets, the higher the incidence of malaria. And so, of course, this group knows that the highest rates of malaria that we see are in Africa, out here in New Guinea, as well as Southeast Asia and South America. So again, anyone traveling to any of these areas, you really need to think about pre-exposure prophylaxis, or if they are a returning traveler, you need to think about whether or not they were in a malarious area. And the U.S. military, they have resources to protect their forces against malaria, but people still get malaria. So we have treated uniforms, and we encourage people to use DEET, and we want to make sure people are wearing long sleeves and long pants, bed nets, all sorts of interventions. People still get malaria. It's typically either when it is speciated, it's either Vivax or falciparum, and then you can see, depending upon where the majority of our forces are and what they're doing, what the locations that make up the greatest amount of malaria. And you can see Africa is the light green, the darker green is Afghanistan, and then we see a good share of Vivax from Korea. In terms of clinically, so the biggest mistake that I see and have seen over my career is that people don't suspect malaria, and they expect that people with malaria are going to present with fever and shaking chills and sweats. And although people can have those symptoms, it's not the only symptoms that you can get from malaria. Sometimes people just report malaise and body aches; they just don't feel well. Or sometimes people will come in with primarily GI complaints, nausea, vomiting, upset stomach. My rule of thumb is anyone who has returned from an area where there is malaria, where you know for a fact they did not take malaria prophylaxis or they didn't take it properly, you really have to assume that it is malaria until you can prove otherwise. Because especially if they're infected with falciparum malaria, then they obviously can they can die from it. And then, so once you suspect that it's malaria, you look at the symptom complex that they're presenting with. The next thing you have to do is make sure that they do not have, or identify if they do, diagnostic features of severe malaria. And I list them in the bottom. They're listed there in the bottom right, which is basically, these are end organ manifestations of infection with the parasite that causes, with the Plasmodium parasites that cause malaria. It's really important to identify if someone has severe malaria or not, or you think they are trending towards severe malaria or not, because the treatment is different. And it could mean the difference depending upon which group you're with and where you are. It could mean the difference between medical evacuation or not, hospitalization or not, pills or IV, whether or not they need to go into a normal ward or they need to go in an intensive care unit and be on monitoring. It makes a really big difference. And so you have to do a real in-depth clinical assessment to see if there are any manifestations of severe malaria. There are lots and lots of algorithms out there for do you think it's malaria? Do you think it's severe malaria? What do you think the species of malaria is? What's available to you? I have found in my experience, even here in New York, that typically I'm always going down the right-hand side. And when you are at the bedside in the heat of the moment, having to make a diagnosis, I suspect it. I do my history and physical exam. I then get a blood smear. I can look at the blood smear, and if it's malaria, I'm not an expert microscopist when it comes to malaria, and you really need one of those to be able to determine what the level of parasitemia is in somebody. So I typically do not have that information available, at midnight on a weekend when I'm trying to determine what to do with the patient. I know where you can know where they traveled to. You can usually do a pretty good job at understanding whether it's severe malaria or not. You may be able to, maybe more than likely not, know what species of Plasmodium it is. So usually I assume I can assess whether it's severe or not, but I just assume it's malaria. it's due to falciparum. I make a determination if it's severe or not, which then allows me to make a determination of whether or not I can treat them with an oral agent, or whether I'm going to call the CDC and get artesunate on site at my hospital. And the other thing is you need to reassess multiple times. I've seen cases start out in the right direction and end up in the wrong direction because people did not do serial evaluations and watch how the treatment either worked or did not work. Okay, we lost. So we used to have quinine, quinidine in the United States. That we no longer have that available, but the FDA did approve artesunate, but the production and access still requires a phone call to the CDC until they can get manufacturing and that sort of thing figured out. Okay, rabies. So in dark blue is where rabies is present on the globe. In dark gray, it's where it's suspected, and then in blue, it is absent. This is for dogs. Okay, this is primarily just for dogs, which in most places where rabies is endemic, dogs can be a major source of transmission. So you can see a pretty there's a lot of rabies on the planet, and a lot of the blue areas are probably areas that both militaries and UN forces deploy to. In the US forces, you can see here from 2011 to 2018, this is the number of animal bites that we've had in our forces every year. And again, the rate line, which is the blue line, or the best fit line, is one of increase. And so we continue to see, regardless of the training and regardless of the rules that we put in place to try to prevent our service members from getting animal bites, it happens. And I'm sure everyone on the call here probably has lots of stories of when you've deployed to different areas to do your work, of people getting animal bites and figuring out what to do. Unfortunately, the hospital I'm at cared for a service member who died of rabies about 10 years ago. So this was a young man who was in Afghanistan and was bitten, and he had not received the effective rabies post-exposure prophylaxis, and unfortunately passed away. The most important thing, which we can all do, and which they estimate reduces the risk of rabies following an animal bite, is washing the wound. So soap and water, 15 minutes, reduces the risk of rabies by about 90% is what the estimation is. And then the post-exposure prophylaxis, the breakdown is whether or not they had pre-exposure prophylaxis. So have they ever been vaccinated against rabies, or have they not been vaccinated? If they have not been vaccinated, then it's a two-step approach. One is with prepared human rabies immunoglobulin plus vaccine. If they've already been vaccinated, then it's just vaccination. Rabies immunoglobulin can be very difficult to obtain depending upon where you are and whether or not they have cold chain and things of that nature. But the point behind immunoglobulin is this initial area down here after you get an initial exposure to rabies. You get bit. There's virus in the saliva. The virus gets into the skin. It starts to replicate. It finds the peripheral nerves. It goes back to the spinal cord and up to the brain, and that's what kills people. And it's 99+% fatal disease. But that takes some time. If you get vaccinated after, on the same day that you get bit, it's going to take at least a week, likely two, for the vaccine to have enough, to stimulate enough of an immune response to protect you against how that rabies virus is going to want to move from the peripheral space up to the central nervous system. And this is where human rabies immunoglobulin comes into play. It is like an immune response in a bag, and it basically, you get it on the day that you got vaccinated, the day that you got bit, and it will help you to bridge between the immunoglobulin or antibodies that are in the bag and the antibodies that you're going to make with vaccination. So that's the importance of HRIG. Okay, MERS-CoV. So there's been 3 severe coronaviruses, beta coronaviruses, so SARS-CoV-1, MERS-CoV, and then what we're dealing with now, SARS-CoV-2. As of June 2021, there have been over 2,500 lab confirmed cases, over 880 deaths. That's a case fatality rate of 35%. So you can imagine if MERS had the same R naught or that SARS-CoV-2 has, especially the Delta variant, we'd be in a much more difficult position even than when we are now. Most of these cases have come from Saudi Arabia, and you can see, just over 2,000 cases. Down below, you can look at the age group for primary infections versus secondary. So primary infection is you had a primary contact with an animal, most likely a dromedary camel, who is infected, and you can see that the age groups of the people that make up the primary infection. So this is the 50 to 59, 60 to 69 age group. Secondary infections are could be when you take care of somebody who is sick and then you get infected yourself. In fact, early on, there was a very high risk of healthcare providers getting infected from patients. So as you would anticipate, the number of the age range of people getting secondary infections is lower. And then in the green, you can see the patients, the percent of patients who died, what age range they fell into. So as mentioned, most of the cases have been in the Middle East, but we've had people who have traveled from the Middle East to different parts of the world, and they brought their infection with them, which meant they brought the potential for outbreaks in the locations that they traveled to. Down below, you see the number of cases by the place of infection. Green represents the Middle East. Red represents outside of the Middle East. So this is mostly a disease in the Middle East, but it continues to percolate. It continues to percolate along, probably in a camel-human cycle. And then I'll just mention this case that where this person flew from Saudi Arabia to out to South Korea. This particular businessman showed us what a super spreader event can look like. This person infected dozens and dozens of people. I think that at the time they published this, that the count was about 30, but it actually turned out to be more than that. And people died, and healthcare workers got infected, and this was just one person that they traced all these cases back to. So MERS is not a good thing. Zika. So Zika has been around for decades, and it's always kind of popped up in Africa, and we've seen outbreaks in Southeast Asia. And then just about 10 years ago, maybe a little bit less than that, about 5 to 10 years ago, we had a huge epidemic, and Zika made its way, not only made its way through South and Southeast Asia, but it came over to the Americas and in the United States. The transmission cycle is kind of interesting because not only can Zika, which is it's a flavivirus, we typically in the forest, it circulates between mosquitoes and monkeys, non-human primates, excuse me, and then a human can get accidentally infected, and then the urban cycle of transmission is human mosquito to human. But you can get Zika from organ donation, blood transfusions, and what's very interesting is that you can have sexual transmission of Zika. And then, of course, what really was the public health burden of Zika, which was transplacental, mother to fetus, and the risk of congenital Zika syndrome, which really made up the public health burden. People who get Zika, they get rash, they get fever, they get conjunctivitis, and headache, muscle aches, very nondescript illness. Most of the people do quite well. So about 80% of people either have an asymptomatic infection or they have a non-specific febrile illness that really doesn't bother them. The 20% of people who get sick will have this type of manifestations that I mentioned. And then a very small percent of them can go on to have major problems like Guillain-Barré, for example. But the vast majority of people do quite well. Again, the public health burden of Zika is congenital Zika syndrome, which can be either phenotypic abnormalities like microcephaly, for example, or you can have a child that phenotypically appears normal, but can have very significant developmental delays. Chikungunya, so this is an alpha virus. It's transmitted by the same mosquito that transmits dengue and Zika and yellow fever. Dark green, you can see areas where there's local transmission of chikungunya. So this is not just travelers. This is local transmission from mosquito to person. And again, all you have to think about is where are the mosquitoes? The viruses can fly in either on a plane and somebody who's infected and doesn't know it, or they can be geographically co-located together and they just cross a border with people. But anywhere the mosquito is and there are susceptible people, there is the potential for infection and an outbreak. And we've seen, this is from 2019, even in the United States, where we have the Aedes mosquito primarily in the South and Mid-Atlantic region, and we had cases of Zika and people coming back to the United States with Zika. So it's something we've had to keep in our, and we continue to keep in our differential diagnoses. The military, our military brought acquired Zika in multiple places, primarily though in Puerto Rico, but also throughout the Caribbean and South America. Typically what will happen is, it's about a week-long incubation period. And then after that incubation period, people start to have fever, muscle aches. One thing that kind of distinguishes chikungunya is people get arthritis. So they can get big, swollen, painful joints. And unfortunately, it can last for weeks, months, and in some cases, even years. And you can see below, this is a person with swollen hands, big swollen fingers, very debilitated. This is the bottom right. You can see the rash that you get with Zika. Again, big, huge swollen tendons, so you can get tendinopathies. And again, another picture of a person's hands, which are swollen, big fat fingers and painful joints. And then there's all sorts of other atypical manifestations. People can get encephalitis, they can get meningoencephalitis, gastrointestinal complaints. So it can be, chikungunya can kill people, especially with people that have a lot of medical comorbidities already. So talking about dengue real quick, this is Albert Sabin. So before he invented one of the polio vaccines, he was in the military and worked on Japanese encephalitis and dengue. So dengue, again, is transmitted. It's a flavivirus. It's transmitted by the Aedes mosquito. So again, anywhere you have people who are susceptible to dengue and anywhere that you have the mosquito, there are potential dengue outbreaks. One thing I want to mention is that a lot of people did not think that dengue was in Africa. It absolutely is in Africa. It just seems that Africans, so people with African ancestry, are not as susceptible to severe dengue. So it was not as much of a public health problem. So people were not counting the cases. But anytime we would send in military forces, for example, US military forces, we would have dengue outbreaks while the community was not. It's still something that needs to be studied and figured out. But there's plenty of dengue in Africa. Most people who get infected with dengue will not have any symptoms at all. And of the people that have symptoms, there's another large proportion that just has this undifferentiated mild febrile syndrome. A smaller proportion, or the tip of the iceberg, will be people who have dengue. The phrase dengue is all inclusive of mild dengue and severe dengue. Mild dengue, people have headache, eye pain, fever, bone pain. So that's one way you can distinguish dengue from chikungunya. With dengue, you have bone pain. With chikungunya, you have joint pain. It's two different things. And one of the misconceptions is that you don't have bleeding with dengue, but you can. You can have nosebleeds and gum bleeding. You can have bleeding at IV sites. Women can have abnormal menses. So that's kind of mild, uncomplicated dengue. Severe dengue, there's two components to it. One is you can have a disruption of your coagulation system, and so people can bleed into their gastrointestinal tract. That's one component. But the real most common component is what we call plasma leakage. So what happens with dengue is that the lining of our blood vessels becomes fragile, becomes leaky, and the proteins leak out from inside to outside of the blood vessels. The fluid follows it, and it puts people into shock. And you can see this as fluid in the chest. You can see it with this little guy who I saw in Bangkok. You can see fluid in his belly, so he's got ascites. And people again can have bleeding manifestations. So here you see the big, huge bruises, and then people get this rash associated with dengue. The way to, and there's about 400 million dengue virus infections every year, and about 100 million people get sick. We probably have anywhere between 8 and 20,000 deaths each year because of dengue, and most of those are in children, unfortunately. The people and the children die of dengue because they don't get to medical care quick enough. Because if they do get to medical care, we have very good algorithms for how to replace that volume that people are losing during that plasma leakage aspect of dengue. And so you can go on the WHO website, and there's some regional WHO resources available. And when you go to Thailand or the Philippines or any other place that they have lots of dengue and they have lots of sophistication in how to treat dengue, you'll see these types of algorithms that are pasted on the wards for people to refer to. Okay, so finishing up, there's a lot of things I did not talk about that are also common problems in deploying forces or travelers. So skin and soft tissue infections. With the abuse of antibiotics globally, we have a lot of multi-drug resistant organisms out there, not just tuberculosis, for example, but other organisms. Sexually transmitted infections, like gonorrhea is probably going to become the first bacterial infection that we are unable to treat because of the drug resistance. Tick-borne diseases is a whole other issue. So Crimean Congo hemorrhagic fever, tick-borne encephalitis in my country, Lyme disease, anaplasmosis, Ehrlichia, Rocky Mountain spotted fever. Now we have Powassan, which causes encephalitis and kills people. Scrub typhus. So tick-borne diseases, and then hemorrhagic fevers, not just Ebola. So there's a lot I didn't cover, but I tried to cover the most, what I thought would be the most common. So I'll go right to thanking everyone for their attention. And if we have any time left, I will try to answer questions.
Great. Thanks so much, Dr. Thomas. This was a great whirlwind tour of all the key important infectious disease threats, even though I know everyone's busy with COVID now, but then, obviously there are other threats as well. Just a quick question in terms of the preparation for pandemics. I mean, that has been happening for the last 20 years. How helpful was it in your experience in terms of application to COVID now? Because I see that it seems that there's a lot of reinvention of the wheel for COVID, when actually a lot of preparation was also put in place for previous, the flu pandemics or Ebola. Just curious to hear your experience on that.
Yeah, I think you're 100% right. And it's been a source of frustration for folks who have been participating in biopreparedness and pandemic preparedness for a very long time. It's very frustrating that we've had to reinvent these wheels. And to me, I personally think that it is because we have never invested in enduring institutions, systems, and processes where their mission and job is to prepare and to have the infrastructure to rapidly respond. And it's all aspects of that. It's not just the minds and scientists and the vaccines. It's how we actually fund these organizations. So for example, in the United States, the Department of Defense Global Emerging Infection Surveillance and Response System, it is funded on a year-to-year appropriation. It is impossible to be bioprepared when you don't know if you're going to be appropriated any money for the next year. And so they invest in very quick hit projects versus investing in enduring systems. So so I haven't been able to break the code. I think the thing that I've applied most, which is what I talked about initially, is just training in leadership and experience in leadership, and being able to assemble and lead cross-functional teams that look at problems from different perspectives, so that your blind spots your blind spots are limited, and you have very broad engagement, and you have everybody owning the problem together.
Great, thanks so much. We have a question, Dr. Grace Fombad, and we're going to spend 5-10 minutes more. So if any of you need to leave, just please go right ahead. We will record it so you can hear the full, all the question and answers. But Dr. Fombad, over to you. Dr. Grace Fombad, do you want to ask your question? If not, let me just quickly ask one about long-term malaria prophylaxis. I was just curious to understand how you do it at the US military. Are the soldiers expected to actually take malaria prophylaxis for the long term, and what is the adherence rate to that?
Yeah, great question. So there have been studies actually in expatriate populations, so non-military, maybe they work for Exxon or some other major corporation, and they go live someplace where there's malaria. They have looked at long-term prophylaxis and primarily focusing on the safety, but also efficacy. When it's been adhered to, it's highly efficacious, and there does not appear to be any safety issues with taking, whether it's doxy or Malarone or whatever you're taking, long-term. In terms of the military, I can remember very specifically advising, because I was the infectious disease consultant to the Army Surgeon General during Operation United Assistance. And she was asking me, all these questions about Ebola. And I said, Ebola is not your problem. Malaria is your problem. We lost about 30 people, 30 Marines in Liberia, not through death, but through needing to be medical evacuated because of malaria. And so through a pre-deployment training, through setting up systems to ensure basically directly observed therapy of the people, of the service members, they did not have a single falciparum malaria infection during that deployment. So yeah, the pills work. If you have nets, that's great. If you have treated uniforms and DEET, that's also great. But the pills are probably your greatest asset. And if you're in a position to do directly observed therapy, that is ideal.
And would you recommend use of mefloquine rather than doxycycline for long-term adherence?
Yeah, so mefloquine has a long story associated with it because of the potential for psychological effects, or people have all sorts of potential side effects. It is a safe drug. It does work. It's just adherence seems to be pretty low. And so I think, and it depends upon what you're doing and the type of activities you're involved in. I mean, if you're involved in, if you're in a very hot area and people are utilizing weapons or have weapons, or you have people who fly planes or helicopters, I think you need to think through that scenarios. So, but fortunately, there's a other than some parts of Asia, artemisinin resistance is still or delayed cure is still relatively low, we hope, and so you still have a lot of choices. The good thing about doxycycline, if you don't, about 5% of people who take doxycycline will have photosensitivity, sun sensitivity. But it also works against a lot of tick-borne diseases. There are a lot of rickettsial infections. So, leptospirosis, 200 milligrams a week of doxycycline will effectively prophylax you against that. And leptospirosis can kill people too, and it's very, very prevalent. So I like doxy.
Hello.
Great. Dr. Fombad, are you able to speak up? If not, Abdur Rahman Joran, do you want to say something?
Hello.
Yes, go ahead. Yeah, your hand's up. Yes.
Good morning, all.
Good morning. Go ahead.
Firstly, thank you for our presentation. I have a question regarding the dengue fever. We know that there are some types of serotypes for dengue. If the person infected with one serotype, it is possible to give him immunity to another serotype.
So for dengue, cross immunity for dengue.
Yeah, right. So there are, thank you. So there are 4 different types of dengue, dengue 1, 2, 3, and 4. And it used to be that you would have one single type circulating in a specific area, and that would be the type for that area. Unfortunately, because of travel and commerce, international commerce, et cetera, now much of the tropical and subtropical world has all 4 serotypes of dengue co-circulating at the same time. You'll probably have a prominent 1 or 2 types at a time, but they're endemic in those places all the time. That is a problem because most people, when they get their first infection with their first type, if kids, usually they're asymptomatic. Adults will typically have kind of mild, uncomplicated dengue. The problem is when you get infected with a second type, more than 18 months after the first infection, your risk of getting severe disease goes up about 50 to 100-fold. No one knows completely why that occurs, but we think it's the immune response that you had after the first type facilitates infection when you get infected with a second type. So what happens is you get infected with that first type, you probably have long-lasting immunity to that first type. You'll have short-term cross protection against the other types. But again, I mentioned 18 months. About a year afterwards, not only have you lost cross protection, but you actually may have increased your risk of severe disease because of that initial immune response. So yeah, secondary infections, those are about 5% of secondary infections will result in severe disease.
Okay, great. Any other
Dr.
questions from anybody at all? If not, I'll just like to end with just one final question. Dr. Stephen Thomas, do you think that with COVID, that militaries around the world will take the infectious disease threat more seriously now? Obviously, I think before it was probably not high on the radar of priorities, but now with this COVID, I assume that some of the lessons learned would be embedded into systems going forward. Yeah.
Yeah, I think when you talk about diseases you can get from water or mosquitoes or ticks or animals, I think a lot of commanders say, listen, the rules that we have in place, you don't play with dogs, you wear your DEET, you take your prophylaxis, you get your vaccinations, and you'll be fine. And through good discipline and command and control, we're not going to have those problems, right? That is not the case with COVID. You cannot escape it. It is person to person. Half of us who get infected and are infectious to others don't even manifest symptoms. So it is a silent enemy which we are not very adept at finding or intervening before it is too late. So I think that you're spot on that this particular enemy is going to get the commanders and the other senior leaders thinking about the infectious disease threat differently. That being said, you can see on our, just in our own military in the lay press, where there is concern about service members not wanting to take even the vaccine. So it's something that, this is where leadership matters, right? This is why you develop the skill set to get people to follow you, even when they may not completely understand, how they're getting to the destination, but they all agree on the destination. They all agree that going from A to B is the right thing to do, and they place trust in you in the pathway that you're bringing them from A to B. So yeah, I think you're 100% right. It's going to change some minds.
Great, thank you so much. I think we've run out of time. It's 10 minutes after, but thank you, Dr. Thomas, for your time. Thank you to all of you for joining us. And if you have any questions at all, feel free to email me at any time, and we will try to answer your questions. But going forward, we will choose another topic for the next month, and it's going to be on public health, maybe on epidemiology, surveillance systems, leadership. Developing your leadership skills. So thank you so much for joining us, and see you next month, everybody. Bye.
Thank you.
Thank you. Bye-bye.
Thank you. Bye-bye.